Thank you, everyone. Thank you so much for having me. It's a pleasure to be here. I'm a breast surgical oncologist as well as an OBGYN, and I'm the medical director of the breast cancer program at Marin Health. So this has been my home base for the last 15 years. And I've had the pleasure, I'm sure, of seeing some of you and some of your loved ones as patients. So it's really a pleasure to be here. Today, we're going to try to understand breast cancer risk a little bit better. A lot of things we're going to talk about apply to primary prevention, but also to secondary prevention. So many of these recommendations and some of these risk factors are applicable to those of us who've had breast cancer in our past. Can I have my slide mover, please? I'm going to talk a little bit about some of the risk factors for breast cancer, and then we're going to talk a little bit about how, about how we can improve our own risk profile. These are the topics we're going to cover, and then we'll have some time for questions. How do we think about breast cancer risk? A little bit about genetic testing, which is one of our sort of frontiers of new care, and then we'll talk about breast cancer screening and risk reduction. Right. Most of us are aware that Marin County is a breast cancer hotspot. So this is true, although less so than it used to be, interestingly, for some complex statistical reasons. Current breast cancer incidence is about 130 cases per 100,000 women, right, which is comparable to similar demographic and socioeconomic counties in other parts of the country. So if we think about places like Orange County or Westchester County, which are similar in terms of how they put together demographically, this breast cancer rate is pretty similar, right? The much higher rates that we're seeing in the late 90s are no longer really seen here. Right. So why was that the case? Why is it the case that this rate is now higher, still higher than many other counties in other parts of the country? Well, we're going to take a look at breast cancer risk factors and help us understand that. And so these are the basic categories of breast cancer risk, right? Breast cancer risk is demographic here, not geographic, right? So this isn't about Marin County as a place, right? It's not about the water or the refinery across the bay or any of that. This is a demographic phenomenon, really. It's about who lives here. So we're going to look at the risk factors for breast cancer. We're going to break down how this applies to our community and then how it applies to us as individuals, right? Average life expectancy for a woman in Marin County is 85.2 years. And the single most important risk factor for breast cancer is advancing age. Right? So here on this graph, you can see how breast cancer incidence increases in 5-year intervals over the course of our lifetime, right? All the way up until we reach 85, and then it starts to go down just a little bit, right? So this is one of the #1 demographic factors. Of course, we can't do anything about the fact that we're getting older, right? If we fail to die tragically young, we're going to get old, right? So here we are, right? And this is one of these non-modifiable risk factors that we have to take into account when we think about how we manage risk in the county, right? The other major category of risk is reproductive risk. So choices that we make across the course of our lifespan for, of course, complex social and cultural reasons that have nothing to do with our breast cancer risk do influence that risk really profoundly. And the way to understand this is that the number of menstrual cycles that a woman has in her life is directly proportional to her breast cancer risk. So those of us who have an early first period or late menopause and fewer pregnancies or shorter or no breastfeeding are going to have increased lifetime risk, right? Age at first period, we know, is getting earlier across the country, right? So that's a phenomenon that's complicated as mostly environmental and nutritional, right? The main cultural factor here is that college-educated women, on average, have their first child 10 years later than high school-educated women, right? And on average, they have 50% fewer children. Right? So this is one of the main associations between socioeconomic status, educational status in this country, and breast cancer risk. Right? Again, we don't make these choices because of our breast cancer risk, but it has something to do with why there's increased risk in a county like this. Right? Breast density is a significant breast cancer risk factor. Right? It's a relatively modest factor, but it's something we have to take into account. And we're going to talk a little bit more about how this plays into mammographic screening later. But we're going to say this is a risk factor, and we know that rates of breast density, which on average is about 40% of women who have dense breasts, are higher among Asian and non-Hispanic white women. So that's, again, a demographic feature here in this county, right? Another thing that we sometimes see is increased risk associated with breast biopsy results, right? So this is less Marin specific, but this is one of the risk factors that we pay a lot of attention to when we assess personal risk. Biopsy itself is not a breast cancer risk factor, right? So it's not the process of the biopsy that has anything to do with cancer risk, right? But there's this underlying phenomenon that those of us who have denser, more metabolically active breasts are both at increased breast cancer risk and more likely to have a biopsy, and we're more likely to have premalignant results on a biopsy. So some of these premalignant results can be associated with increased lifetime breast cancer risk, and it's something that we pay a lot of attention to on the clinical end. Hormone replacement therapy, right? This is a very hot topic, and we're going to talk a little bit about this later on. But there's some basic things that we can say about the role of hormones across our lifetime, right? Postmenopausal hormone replacement therapy is tied to better healthcare access and socioeconomic status, right? So this is a risk factor in this county, right? There are more of us on postmenopausal hormone replacement therapy. There are definitely safe roles for the use of hormones. And in fact, there's going to be a whole session on that later. The lovely Dr. LaFollette is going to talk a lot about some of the things that we do with hormone replacement therapy over the course of the lifespan. Right? Here we're just going to focus on what the application of this to the question of breast cancer risk. Right? So hormones are, of course, very complicated, and they are neither exclusively good nor exclusively bad when we think about their role in our health. Right? There are a few things that we can say about the relationship between supplemental hormones and breast cancer risk. And one is that post-menopausal hormone replacement therapy, that means after we are completely done with our menopause and for relatively prolonged periods of time, 5 years and greater, have been pretty convincingly associated with modest increased lifetime risks of breast cancer, right? This data is complicated. There's a lot of controversy around it, but these are enormous studies, right? And so the statistical weight is pretty much there, right? So we can say this is probably a modest risk factor for breast cancer, right? And certainly it played a role in the increased rate of breast cancer in Marin County in the 1990s, as well as across the country. When women started coming off hormone replacement therapy in large numbers in the early 2000s, breast cancer rates went down right behind it, right? So epidemiologically, this is not particularly mysterious, right? That said, there are a lot of other ways that we can use hormone replacement therapy. I'll talk a little bit about this later, but it's clear that women who are perimenopausal, right, women between 45 and 55 who are symptomatic from menopause can very likely, again, data are a little bit mixed, use hormone replacement therapy safely to help themselves be less symptomatic through that process, right? And that there are some uses of hormones, like the application of vaginal estrogen, which are safe for almost all women at almost all phases of life, with a few exceptions, right? So some of this is, we have to be a little bit careful about thinking about individual risk, right, and context, rather than hormones all good, hormones all bad, right? And again, Dr. LaFollette is going to get into some of that in a lot of detail. Family history, often perceived as sort of the breast cancer risk factor, is in fact really only a modest influence on our lifetime risk and is very contextual, right? So for example, a woman who has a first-degree relative, like her mother, who had early onset breast cancer, is going to get more statistical lifetime risk out of that than someone who has a postmenopausal second-degree relative who had breast cancer. 1 in 8 American women will get breast cancer in her lifetime, and when we start counting up our relatives, we're going to get to 8 pretty quickly, right? So many of us are related to somebody with breast cancer in a way that's not going to have an enormous amount of influence on our statistical risk, right? The reality is, statistically, that most women who get breast cancer have no family history, and most people with a family history never get breast cancer. But there are some things that we should be paying attention to. We know that people with a first-degree relative, that's a mother, a sister, or a daughter with breast cancer, are going to have some increased lifetime risk. That's the red line compared to the black line, which is the whole population. Right? So this is something that we ought to be paying attention to. And we know that there are some people who are very elevated lifetime risk of breast cancer because of their family history, right? So these are genetic mutations that some of us come into the world with, right? We get them through our family line, we carry them all our lives, that increase our lifetime risk of developing certain types of cancers, right? Most breast cancers are sporadic and not associated with this kind of genetic predisposition, right? But about 10 to 15% are associated with a lifetime risk that people come in the door with, right? And that's something that we need to be aware of. And ideally, that we're finding out before people have a cancer event. So we'll talk a little bit about how to know if you need genetic testing, who's a candidate, what kinds of families we're paying attention to. This is a very rapidly evolving area of science. We are learning so much about human genetics. And the mountain of what we could know about it just goes up into the stratosphere. It's incredibly complicated. So this testing continues to evolve, right? We'll talk about state-of-the-art testing, what's happening right now, and then what we can expect in the future. We'll talk a little bit about modifiable risk factors, right? What are the risk factors that we have control over, right? Because most of the things we've talked about, we basically are either too complicated to control, like reproductive choices, or are just out of our control completely, right? So modifiable risk factors altogether are going to have only a modest effect on our overall lifetime risk, but these are the things that we have some control over, and they're an important part of the risk picture, right? The single most effective intervention for cancer risk reduction is moderate cardiovascular exercise. And this is true of breast cancer, and it's true of most solid tumors and many other types of cancer, right? Why is this, right? So this gives you sort of a general overview of the things that exercise does to our body, right? Maintains a healthy weight, helps us metabolize our hormones, supports healthy digestion, right? Has a profound effect on our microbiome, right? Which is part of our digestive process in addition to other things, reduces inflammation and boosts our immune function, right? Cardiovascular exercise does not have to be miserable, right? It can be fun, all right? As long as your heart rate is up, it is cardio, right? Weight management is another important part of our risk profile. Right? For every 5 pounds of weight that a woman gains after menopause, her breast cancer risk goes up by 1%. Right? Why is this? After our ovaries stop being the primary source of estrogen in our bodies, we continue to make estrogen. We make it in our adipose tissue, in our fat tissue. Right? The more of that we have, the more circulating estrogen we have. Right? So the math is actually pretty straightforward. So weight stability through the second half of our lives is very protective against breast cancer risk. Right? Alcohol consumption. Alcohol is a carcinogen at any dose. Sorry, just is. Right? We know that for women who consume a drink a day, breast cancer risk is increased by 7%. For women who consume 2 to 3 drinks a day, it's increased by 20%. Even light drinkers, those who consume 1 to 4 drinks a week, have measurable increased breast cancer risk compared to those who consume no alcohol at all. Why is this? Right? Alcohol is a carcinogen. That's one reason, right? The other reason is that it has some very specific effects on our circulating estrogen levels, right? Alcohol takes our, a simple way to understand it is that it keeps our liver busy. And one of the things that our liver does is chew up and excrete our estrogen-type hormones, right? So if your liver is busy doing other things, it's not doing that. And so circulating free estrogen levels are going to be higher after alcohol consumption. Right? So this is something that we all need to consider as we think about how we interact with that in the latter half of our lives. This slide is intentionally confusing, right? Environmental exposures to carcinogens are incredibly complicated, right? And this is one of the simplest things that I could find to help summarize it, and the credit that I put on this actually fell off the slide, which I apologize for. This I got from Zero Breast Cancer, so thank you to that organization for this slide. And it summarizes some common household carcinogens, right? So summary slide on this is pretty straightforward, right? Very simple things that we can do. Don't smoke. Make sure our furniture does not have flame retardants in it. Our mothers were right. A clean house is healthier for us, right? We live in a very complicated chemical environment. And keeping the air in our home and car filtered and keeping our home clean actually protects us against carcinogens that can accumulate in our home, right? Cosmetics and personal products are a large source of carcinogens, particularly in this country where these products are not very heavily regulated compared to, for example, the European Union. Right? There are some very good apps that you can use to look at the kinds of personal care products that you have, and that will help you understand those that have carcinogens like parabens in them and those that don't. All right? The one that I like the best is the Environmental Working Group's app called Healthy Living. It's something that's easy to have on your phone. Environmental Working Group is a really terrific source for a lot of information about environmental carcinogens. Okay. Avoiding plastic on our food and nonstick pans, buying organic and washing our food. And in general, foods that are high in saturated fat are going to have higher concentrations of pesticides, right? So we often associate pesticides with vegetables, right? But as in fact, what happens with pesticides is they get into the food system and they get more and more and more concentrated the higher up the food chain you get. Right? So the highest concentrations of pesticides are generally found in meat and high-fat dairy products. Right? So this is one of the reasons that a diet high in saturated fat is associated with an increased cancer risk, both breast cancer and many other types, particularly colorectal cancers. Right? So this is one of the things that we can do to help keep our diet clean. Modern life is a very complicated chemical place, right? So one of the things that I always tell my patients is don't make yourself crazy about this, right? Do these really simple things and then just don't worry about it, right? Because you have to give yourself a certain amount of grace, right? We all live in this environment. There's only a certain amount we can do about it. Right. We're going to change gears for a minute and talk about genetics. Right? This is, as we said earlier, an area of very active research. There's a ton going on here. It's been really interesting. We go to conferences, and I like to call the folks who get up with their complicated slides the alphabet soup people. Right? There's a lot of alphabet soup up there, lots of letters. Right? And they're doing some really, really amazing work. As of now, we know about 100 genes which are associated, if mutated, with increased lifetime cancer risk. And usually that cancer risk crosses organ systems, right? In other words, these mutations are found in all of our cells. And so while some of them are associated with increased breast cancer risk, they can also increase risk of other types of cancers. Some are more heavily associated with, for example, colon cancer risk, but then also may cross organ systems and increase our breast cancer risk as well. Right. This testing has been available since the 1990s and has been getting more and more and more complex over that period of time. Right. We started off with the BRCA1 and 2 genes, right, which most people are familiar with. Right. These genes were sequenced by Mary Claire King and her team in Seattle in the early 1990s. And since then, we've found more and more and more parts of the human genome that are associated with cancer risk. All right. So who should have this testing? Over this period of time, indications for testing have become broader and broader and broader, right? Because we've understood that although there are some families where risk is extremely high, there's also a lot of mutations that can increase risk modestly, right? So these are just some examples, right? Anyone who has a new breast cancer diagnosis in this country generally will get genetic testing, right? Those with a family history. Any American of Ashkenazi Jewish descent is a candidate for testing because of the higher concentrations and mutations in that ethnic population, right? People with multiple cancers on one side of the family, and so on. So these indications, again, are getting broader and broader and broader over time. This testing is valuable for both men and women, although the expression of these mutations is sex-specific. Their inheritance is not. Right? So this is not something that you're more likely to get from your mother's side than your father's side. Right? These are dominant mutations which can be passed down either side of the family. Right? And this testing can be valuable for men as well. So this is something that's useful for us to know about. This testing is relatively easily accessible, right? And it has gotten less and less expensive. Right? When it first came out, it was prohibitively expensive and difficult to get authorized because the guidelines were very restrictive, right? Now those guidelines have really loosened, and this is relatively easy to get. If you think you're a candidate for genetic testing, you live in Marin County, and you're over 40, the easiest way to get this testing is to go get a mammogram at the Drake's Landing Center, right? You give them a family history out to 2 generations. They will flag you for testing. They will bring you in for testing, and they will give you a result. I think we're going to do questions at the end, if that's okay. Sure. The easiest way to get testing in Marin County is to go get yourself a mammogram at the Drake's Landing Center, right? When you come in for a screening mammogram, they will ask you about your family history, provide your family history out to 2 generations. They will flag you for risk, and they will bring you in for testing. You can also come to my office, and your primary care provider can refer you to UCSF. They have a great genetic counseling team there. They will do video-based genetic counseling, and they will send testing kits to your home. Right, so this testing is really quite accessible. Right. The new thing in genetic testing is this thing called polygenic risk, and this is going to become more and more part of what we're doing. Right? Polygenic risk is a way of individualizing statistical risk using what we call non-coding parts of the genome. Right? A lot of our DNA isn't apparently doing anything, right? It's not actually genes, it's sort of background noise, right? And in that DNA, there are a lot of sort of flags that we can follow through the population, right? So this type of risk modeling means taking into account statistical risk factors for an individual and then looking at their individual genetics and placing them on a risk profile. And what this graph just shows you is, hey, this actually works a lot better than statistical modeling alone. So if we compare people who've had this type of testing and shown to be at increased risk compared to those who've had this type of testing and shown to be low risk, we see significantly different rates of breast cancer in these 2 populations, right? So this is sort of the new frontier in terms of how we think about genetic testing, not just genetic mutations, but also sort of who we are in relationship to the whole population, and how that can help us individualize our breast cancer risks. All right. We're going to switch gears again and talk about everyone's favorite thing to hate, mammograms. So mammography has been the subject of a great deal of debate, some of it played out in public, all right? So even among experts, there's a certain amount of disagreement about how we should be using mammograms, right? And what is the appropriate balance of risks and benefits, right? So important just to say out loud, everything we do has benefits, hopefully, and downsides, right? That's just the baseline, right? That's the expectation, right? All studies have false positives and false negatives. So when we ask ourselves the question, does this healthy person have X disease, right? If they're coming in the door with that disease, there's the chance that we're going to find it and the chance that we're going to miss it, right? False positives, right? And then there's false negatives, rather. And then if the person's walking in the door without the disease, there's the chance that we're going to see something that isn't cancer, and that we're going to have to call them back, and we're going to have to work it up, and it's going to turn out not to be anything, right? False negatives. All studies have false positives and false negatives. So the core of the debate about mammography is the appropriate balance between false positives and false negatives, right? We don't want to miss breast cancers. We don't want to send you home saying you're fine if there's actually a cancer there. But we also don't want to call everyone back for background noise that isn't anything, right? And we always have to work on striking that balance, right? We also know that overdiagnosis is a real phenomenon, right? What do we mean by that? Overdiagnosis means we find a small precancer or a small cancer in a healthy woman who would have died of something else before that cancer became clinically apparent, right? But we don't know that, right? And it's impossible to play that tape forward, right? So this is something that we know to be a phenomenon, but it's also something that is difficult to individualize, right? Is this particular cancer an overdiagnosis versus something that would actually have been a clinical problem? It can be hard for us to know, right? So the public and personal health costs of any screening test are a real thing. And the question is, how does that balance against the real benefits, right? So there is an enormous amount of data to show us that mammography is helpful. Let's see, we'll talk for a second about this, right? Mammography is the gold standard screening test for breast cancer for a reason. There is an enormous amount of data showing us that regular screening mammography reduces the stage at diagnosis. Stage at diagnosis is the most important indicator of prognosis, right? And even in women with extremely dense breast tissue, mammography will pick up the majority of breast cancers, right? So this is the gold standard test for a reason, right? It is a safe test. If you get a plane and fly from San Francisco to Chicago, you get more radiation exposure than you do from a mammogram. It takes 40 mammograms to make as much radiation as you get in a CT scan, right? So medical radiation is a real concern, right? But mammography is all the way down on the low end, right? And we know that women who get regular mammograms across the course of their lives are at no increased risk of developing a breast cancer that could shorten their life expectancy, right? So this is a safe test. It can't be fantastically comfortable, but we have learned to make them more comfortable, right? The mammogram center at Drake's Landing has curved paddles, great techs, lots of experience. So we try to make the study as comfortable as we reasonably can, right? This is a very straightforward study, right? And we know that it helps. For average risk women, national recommendations, which of course have slid up and down the age range a little bit, right? And there's a fair amount of controversy around this. Current national recommendations are to begin screening at age 40, right? Screening early increases the risk of false positives and increases the number of life years that we save, right? Early diagnosis for a woman in her 40s is more likely to extend her life by 30 or 40 years compared to early diagnosis for a woman in her 70s or 80s, right? So when we think about how many productive life years is a mammogram saving, screening younger women has potentially more benefit even though there are fewer cancers in that age range. Interestingly, we are seeing the average age at breast cancer drop, right? And we're seeing that for a number of other cancers as well, particularly colorectal cancers. There's been a big uptick in aggressive cancers diagnosed in women in their 20s and 30s. And we know that that's probably environmental, although we don't really understand what's going on, right? So that's a trend that's just begun over the last 5 years. And how that's going to influence screening recommendations remains to be seen, right? We do recommend annual mammography. Annual screening is not arbitrary. It is based on the natural history of breast cancer. It takes about 12 to 18 months from the time that the cell goes haywire to the time that the cancer is detectable by mammography, right? So the 12-month interval is not just for your convenience, right? It actually has to do with how long it takes for the breast cancer to present, right? The age to stop screening is going to depend a lot on life expectancy, right? So when a person's life expectancy is less than 10 years, then the benefit for mammography is really low. Where that point is for an individual, of course, is going to be very variable, right? Over 75, it's a personal decision that a person should make with their physician, right? So what do we do for women who are at increased risk? The most valuable adjunct screening is a breast MRI, right? So the value of breast MRI is that it has a very, very low false negative rate, right? If you walk in the door with a breast cancer and you have a breast MRI, we will find it, right? The downside is that it has a very high false positive rate. Callback rate is very high, right? So we are asking people to come back and have more studies and have biopsies for a lot of things that are going to turn out not to be cancer. That's why we only do this in women at increased risk, right? It's not an appropriate test for somebody at average risk, right? Contrast-enhanced mammography is coming down the pike, right? This is not available in most places now. They have just in the last 6 months started to do a few of these at UCSF on kind of an experimental basis, right? This is a regular mammogram with a shot of contrast material before you have the study, right? This is the same contrast material that we use for CT scans, right? So this improves detection somewhat, decreases false positives somewhat, right? This is probably the next new thing, right? But it's going to take a little while to be completely integrated, right? Breast ultrasound has a lot of press, right? And so it's important to say, ultrasound is an incredibly valuable diagnostic tool. If you come in and say, I have a lump, right? Or if your mammogram is abnormal, right? Then ultrasound is our most valuable tool. It is a terrible screening tool, right? So if we just take an ultrasound and go, I wonder whether there's anything going on in this breast, we're going to get very high false negatives and very high false positives. So whole breast ultrasound for screening, while it is used at some institutions in some parts of the country, is widely agreed on to be not a good screening tool, right? A valuable diagnostic tool, but not a good screening tool. And in this county, where we have easy access to breast MRI, which is much better on a bunch of ways, we don't use whole breast ultrasound. Right? We'll say one more thing about screening, which is that there are a number of screening strategies out there which do not have validated data and are not helpful, among which thermography is one of them. Right? This is a study that was marketed as an alternative to mammography, but in fact does not provide any alternative screening, has never been validated, and the FDA has sort of come after this as this is sort of a snake oil thing. Thermography just doesn't work. All right, so we'll just talk for a few more minutes about what we as individuals can do, right? If you think that you are at increased breast cancer risk, then seek a specialty referral, right? Individuals at increased risk should have an annual MRI, should follow risk reduction guidelines, and can benefit from counseling and potentially genetic testing, right? Talk to your primary care provider, talk to your gynecologist, and the breast surgery office at Marin Health is available to help you. Anti-cancer lifestyle is really pretty simple, right? You can buy 100 books on this. You can listen to 1,000 podcasts, right? These are very simple guidelines. Exercise regularly, follow a plant-based diet that's low in saturated fat, low in processed sugar, with 0 to low alcohol consumption, and avoid environmental carcinogens to the extent that you can, right? This is really, really simple advice, right? For individuals at high to very high increased risk, there's some additional interventions, right? We do put some people on medications, right? Some of these medications have been shown to reduce lifetime breast cancer risk up to 30 to 50%. This is a whopping amount of risk reduction, right? Way more than we get from anything else we can do. But we're asking people to take medication for a disease they don't have, which is kind of weird, right? So this is something that we use judiciously, that we use for women at really increased risk. And there are some new studies looking at much lower dose approaches to this, which may become more and more part of our clinical practice as we go through time, right? I do certainly talk to people about surgical risk reduction, but these are pretty limited indications, right? Folks who really need surgical risk reduction are a very, very small minority of the population. Right, this tells you a little bit about medication for risk reduction, which we'll skip over in the interest of time. And again, these are our take-home notes. Breast cancer risk is complex and individual. There are individual statistical models available online, right? You can talk to your primary care doctor or your gynecologist about estimations of your individual risk, right? We never get to know why a particular person gets a particular cancer in a particular year, right? Cancer causation is incredibly, incredibly complicated, right? But we can know sort of where we fall in these risk profiles. Right? We can support our overall health and our risk for all cancers with pretty simple lifestyle interventions. Right? Hormones are not universally good or universally bad. Right? It's all about context. Right? And depending on where your personal risk is, what kind of symptoms you're treating, and where you are in your life, and what kind of other medical problems you might have, hormones may or may not be a safe and reasonable option. All right? Mammographic screening saves lives. Come and have your mammogram. And if your risk is high, we're here to help. And that's it.
Thank you, Dr. Kelly. That was a very interesting and informative presentation. And now we're going to have time for questions and answers. So if you want to go ahead and raise your hand, myself and Sally will be running mics to you. So if you have a question, this is your time to ask one.
Good morning and thank you. My question is, I have 2 daughters in their 40s and they have had mammograms. Do they get them annually?
Annual mammograms after 40.
Thank you.
even for women at average or low risk.
Is there anything you can do about dense breasts?
Breast density is a lifelong characteristic like eye color, right? It really is how we are put together. There are some things that influence our breast density. All right, part of it is our hormonal environment. So we know that our breast density will decrease slowly after menopause, right? But if we start at the densest end of the spectrum, we're not going to end up all the way down at the other end, right? We're going to have some slight decrease in breast density after menopause, right? There aren't a lot of other things that we can as individuals do, right? That's sort of how we're put together.
Dr. Kelly, early on you showed slides of the age-related incidence of breast cancer, the bar graph, and it looks like the incidence continues to go up to age 85. But in your recommendations for mammography, 75 is, quote, the cutoff? What's going on?
Yeah, really interesting problem, right? That has to do with the fact that the benefit of screening is something that we see over time, right? So when you find a small cancer, right, the potential cancer-related death that you're preventing is typically 5 to 15 years away. And so when our life expectancy is only 10 or 15 years, then documenting that you're actually saving individual lives is statistically very difficult, right? So this is why the decision to screen after 75 is an individual one. It really has to do with the individual person, how healthy they are, what their individual life expectancy is, right? We recommend against mammographic screening in somebody with a life-limiting medical diagnosis, right? So if you are already living with another type of metastatic cancer, for example, we usually will not screen, right? On the other hand, particularly in this county, there are a lot of women 75 and over whose life expectancy is at least 10 years and probably closer to 20. So for those folks, it's absolutely reasonable to continue doing mammograms, right? The statistical reality is that no matter how diligent we are about our health care, most humans don't get to be 100. Right? And so we have to think judiciously about what we do after 75 because healthcare interventions have increased costs, particularly just in terms of how much they take out of us as we get older, and they have decreasing benefits. So it's very individual.
I'm currently 81, and I've been just getting the notices from the center for, in Larkspur Landing to come and get the mammogram. And am I going to live to be 91?
I wish I could tell you.
I mean, this is something that, I'm still getting the notices, and I go in annually.
Yeah. So this is a question to talk about with your primary care provider or gynecologist, right? Again, we are notoriously bad at predicting how long individual people are going to live, right?
Okay, because I was thinking that,
generally
this age,
speaking, if we're pretty healthy, it's a reasonable thing to consider doing in the context of your overall health.
I think I'm pretty healthy.
Is the genetic testing also recommended if you've had breast cancer surgery in the past?
Yeah, so the guidelines have been changing pretty rapidly. And within the last few years, there's been increased consensus that anyone with a new breast cancer diagnosis should have genetic testing regardless of family history. Because the data show that if you're just talking about people with a new breast cancer diagnosis, if we follow testing guidelines and only test those with family histories, we're going to see genetic mutations in about 10% of people. If we test those without family histories, we're going to find another 6% who are walking around with a genetic mutation that we didn't know about. In women with a diagnosis, right? People without a diagnosis are a little bit more complicated, right? So if you have a personal breast cancer diagnosis in the past and you've never had genetic testing, you are a candidate, and you can talk to your providers about that. That's
Genetic testing that's done at the time of the cancer being removed?
There is genomic testing that's done on the tumor. That's a different animal. Mm-hmm.
over there, and we did have a request that you repeat the question, because I think not everybody's
Sure,
hearing the
thank you, I
question.
will.
Well, I had two questions. One is general, and one is not so much. One is, could you speak to the cancer clusters in Marin County? Should I move? And the second one is more specific. I need a physical therapist who deals with the breast after lumpectomy, a specialist.
Yeah. The first question was about the breast cancer rates in Marin County. As we talked about at the beginning of the talk, those rates are pretty stable. It's been about what we would consider to be high average rates of breast cancer in this county, comparable to similar socioeconomic counties. This is a demographic phenomenon, not a geographic phenomenon. It doesn't have anything to do with where we are. It has to do with who we are, right? I'm happy to talk to you afterwards about referrals to physical therapy.
Is there risk data available regarding cell phone usage or habits and travel-related radiation?
Yeah, great question. So there's no indication that cell phone use is associated with breast cancer risk particularly. This type of thing is very, very difficult to study because of the complexity of the variables, right? Everyone has a cell phone now, right? Pretty much everyone, right? And those who don't also have a lot of differences in their lifestyle that might also accommodate those, might account for some of those differences and risks. So that type of question, while really interesting, is also extremely difficult to study, right? We do know that frequent plane travel, again, thinking about how we are exposed to radiation when we're up in the atmosphere, as well as some of the physiologic stressors that come along with frequent travel. Frequent plane travel is associated with a small increased lifetime risk of breast cancer. Flight attendants particularly are a population among a few others who are at increased lifetime breast cancer risk, right? Another interesting group being female physicians, right? So there are some populations that are at increased risk because of a variety of environmental and occupational exposures.
Can you quantify frequent travel?
I actually don't know whether there is a number that goes with that. I would have to look back at that data. Yeah.
Dr. Kelly, thank you so much. It's been so interesting. I'm really enjoying this. And going along with the modifiable risk like flying, I am a former flight attendant, so I'm glad I stopped doing that. But regarding microwavable food and like plastic utensils and stuff like that, could you address that?
Sure. So again, our chemical environment is a very, very complicated place. And quantifying the amount of additional individual cancer risk that's associated with something like, whether you store your food in plastic or not is really very, very difficult to do. Right. I think the best things we can say come from some basic science data, which suggest that if we move our food out of plastic containers, right, and that includes plastic containers in our homes, it includes what we buy and what it's packaged in, we can reduce the detectable levels of a number of plastic-based carcinogens in our individual bodies, right? The degree to which that actually influences our individual cancer risk is much more difficult to put numbers on, right? But in the big picture, those are probably good ideas, right? The less gunk we have in our bodies, the less work our bodies have to do, right?
Other questions?
Was that up here?
Oh, okay.
Any data on breast reduction, how it affects cancer risk, or is there more or less because there's less breast tissue, obviously, so any studies on
the
that?
The question is about breast reduction and whether having a breast reduction influences our breast cancer risk. It does not, is the short answer, right? Breast size and breast cancer risk are not correlated. So cup size has nothing to do with breast cancer risk, and whether or not you've had a breast reduction has nothing to do with it.
I saw that men, of course, get breast cancer. And how is that usually detected?
So yes, men do get breast cancer. There's about 2,000 cases of male breast cancer, male breast cancer in this country every year. This is, compared to almost 300,000 cases of female breast cancer, right? So it's a very rare event. It's something that I see maybe once a year. I'll see one, and they're almost always palpation detected, right? So there's generally a mass, and because there's not a lot of surrounding breast tissue, those masses are typically very easy to detect. Stage for stage, male breast cancer is significantly more aggressive and lethal than female breast cancer, and it's a fairly complicated phenomenon. There's not a lot of data on effective treatment, again, because this is a very rare event.
I don't know if this is on.
Yeah, just talk
Loud. Corollary to her request or her request for information on breast reduction, what about breast enhancement? Any data about relationship between breast cancer and
Yeah, great question. The question was about breast augmentation, the placement of implants behind the breast. So there is no data to suggest that breast augmentation increases breast cancer risk. There is good data to suggest that people with breast implants have a higher false negative rate on mammography, largely for technical reasons. Right, it's much more difficult to detect breast cancers in the periphery of the breast, right, when there's an implant in the way. So that can be associated with an increased stage of diagnosis, but incidence, no.
All right. Well, I think I see a hand back there. If you can get that over to her. And real quick question. How much can you modify your breast cancer risk by changing lifestyle factors?
Yeah, so how do you change your risk? Not all that much, in the sense that the bulk of our statistical risk comes from factors that we have no control over, right? Having breast tissue to begin with, right? Getting older, our family histories, and again, our reproductive decisions, which are complex social and cultural decisions that we don't make for breast cancer risk reasons, right? So most of the horses are out of the barn before we start. Right? So the things that we have control over will have some modest impact on our risk, particularly over the course of our lifetime, right? So if we stick with healthy habits beginning before menopause and into our postmenopausal years, we're going to have some measure of decreased risk, right? It's very difficult to quantify, right? Because these are really, really complex variables. But as a general rule, we can say it's probably a quarter of our overall risk profile.
Back there, and I think that's going to be our last question.
Yes. If I go to Drake's Landing and I get the kit, the genetic kit, is that broad-based or is it specific for breast cancer?
The panels that we're running are specific to what are called cancer predisposition syndromes, right, which are mutations that increase cancer risk over the course of the lifetime. Standard panels include mutations that affect primarily breast cancer risk, as well as a number that primarily affect other types of cancer risk, like colon, melanoma, et cetera.
Would that be lung also?
Yes, there are fewer syndromes that impact lung cancer risk, which is primarily environmental.
Okay.
All right, thank you. Let's give Dr. Kelly another round of applause.